I mean, what happened is due to conversation. We didn't get the time necessary to, at the PEB board meeting, excuse me, a conversation over other items. We didn't get the time to really delve into the issue of a third PEB board member, and
Okay.
then they also just needed to give their final approval because we were waiting on the OEB board to make their, which they did in December, their approval for a joint work group.
Sure. Okay, the reason I'm asking this, because I'm about to bring the meeting to order, is because I'm not sure how to handle the first agenda item. But let's call the meeting to order. This is the Strategies, Evidence, and Outcomes Work Group meeting under the PEB and OEB. January 7th, time is 10:02 a.m. Let's look and see who's here. And this is why I'm kind of saying, so for OEB, of course, I'm here. Enrique, I think, was going to join because I just sent him email, but I don't see him on the list yet. Enrique, are you there? And Dr. Laura, I'm not sure her status.
I'm here.
Oh, you're here.
Yeah.
Good.
Yeah.
I see you now. I've got to scroll down, up and down the list here. Okay, good. So we have Dr. Laura and myself, and I think Enrique is going to join in a minute.
Is Robert here?
Oh, sorry. That's right.
Yes, I just got on. Sorry.
My bad. I'm doing this backwards, right? Robert. So we have 3 members from PEB, or sorry, from OEB. And I see Greg from PEB.
And then is Adrian? Is she
Adrian,
Yeah. Oh, Andrea's here.
here? Oh, Andrea.
Oh, Andrea.
Right?
I'm
So
sorry.
Andrea,
Yeah, that's
so we
okay.
have-
If it has an A, I'm good.
Okay. And we're only going to have 2 members from PEB. So we have 5 of 6 potential seats here. So, okay. So now it makes it clear for me. Thank you for everybody on the roll call. So first agenda item is our meeting synopsis. And the last meeting we had was in September. And I'm not sure why we're doing May. Did we not do September?
We didn't have a September, October, or November meeting. Or sorry.
So we didn't have October, November, right?
That's just a typo. It should be the September and December meetings. We already did May.
Okay.
Sorry.
Right. Okay, that's why I was okay. No problem. So here is the synopsis of the people here. Do we have any questions on the synopsis for those meetings? Okay, hearing no questions, can I have a motion to accept the meeting synopsis as presented?
I move that we accept the meeting synopsis as presented.
Anybody want to second that? I'm staring at Greg, but I see his mouth moving.
I
but I don't
second that.
Okay.
Yeah.
I hear a second. All right. Thank you. All in favor of accepting the meeting synopsis as presented, say aye.
Aye.
Aye. And anybody opposed? All right, we'll go with that. I need to make sure I keep it straight here that Andrea and Greg and the third party chair are now voting members of this work group. So make sure we have so we have 5 votes in the affirmative there for that. All right. So let's go ahead, and so we'll just mention that next month we'll work out the leadership positions for the SEOW team here and get that all formalized. All right, that takes us now to agenda item 2, which is our medical quality performance metrics, going to be done by each of the medical carriers. I believe first up we have Kaiser. Dr. Bachman, is that you?
Yes, that's yes. Thank you.
Hold on.
Keith can be, and Bill, before you jump in, it's since we have a new member, we PEB OEB has a set. I just wanted to make sure everyone understood. PEB OEB, it has a set of really quality medical quality performance guarantees that we require of the three carriers, both for OEB and PEB. And we've asked them to come in to do the 22nd and the 23rd measurement years to provide, how they performed, if there's any ones that are below the PGs, what their action plans are for improving. And then third is to provide any suggestions on possible changes to the PGs, especially around ones that say would have a clinical care quality impact on our clinical care impact on the OEB-PEB population, or say ones that where NCQA is really disenrolling the measure. So I just wanted to give everyone kind of just a brief synopsis on that. Dr. Bachman, you can go ahead.
Great. Thank you very much, Glenn. Happy to be presenting on our quality performance metrics today. I just want to make a quick personal note that next month was my last meeting with SEOW and OEB, as I'll be retiring shortly thereafter. I do also want to introduce, before I get to that, I just want to say it's been working with the OEB team and the OHA staff for both OEB and PEB, and the consultants have really been one of the most important professional experiences that I've had, and really I believe the work that we're all doing together, both with the other plans and with the staff, has important implications for the health and well-being of our OEB employees and PEB employees, as well as, I think, leading the ground for important work for the state. So I just thank you all for your collegiality and comradeship in this work, and thank you for the opportunity you've done this over the last 12 years. So Mark Mueller will be co-presenting with me today, and Dr. Mueller is a family medicine physician with Northwest Permanente based in Eugene. He's the quality lead for the Eugene service area. And he also has an important professional background in addition to his primary care work that's going to, I think, serve OEB and PEB very well. He's a clinical epidemiologist, has a master's in public health degree, and has also done work with the CDC as a clinical epidemiologist. So I think that background, both OEB and PEB will be well served with his expertise. We can go ahead to the next slide, please. So this is kind of the broad overview of where we were over 2023. We do have the 2022 data in the appendix. And as you can see, what's indicated in green is the numbers that have exceeded the 75th percentile. And we even have more 75th percentile. And you can see even that 75th percentile column in the green there, if you look back to 2022, you'll see that the benchmark increases every year. So you even achieve the 75th percentile gets to be more challenging every year. Those benchmarks are a little bit different, they're a little bit more stringent for an HMO benchmark compared to a PPO. And we are being measured against the HEDIS 75th percentile HMO metric. You can see many of the metrics are in the green, or most of the metrics are in the green. Where you see an arrow are things that have improved from 2022. The few things that were noted to be much better from 2022 includes adolescent immunization, which is improving. That's really important. We are starting to see the long-term data of the HPV vaccination that's being given in reductions of the rates of invasive cervical cancer and death from cervical cancer. So that adolescent immunizations are really paying off. We did see nice improvements from 2022. Another place we saw improvements in colorectal cancer screening. I think that was really coming back from the pandemic. And a third place that we were seeing great improvements from 2022 was in A1C in poor control. Generally, OEB and PEB runs together. There's a few places where there are slight discrepancies. You can see lower rates of childhood immunization For PEB, which OEB does hit the 70th percentile, and PEB does not for the Kaiser population. And you can also see some difference around statin therapy for cardiovascular disease, which is higher in PEB than OEB. Hard to know what that means. It's probably for that measure particularly, it's a fairly small number of people. And the last measure there was the final CAP score around getting needed care. We are seeing very large improvements from last year. They're still not quite at the 75th percentile, but that is one area that the healthcare system is, our healthcare system is focusing on, is really access and service. And that's really what drives that getting needed care composite. So that's kind of performance for 2023. Continued good performance, always areas of improvement. Dr. Mueller will be talking about some of the measures in more detail. Next slide, please. So these are the measurement changes, and you can see that in 2023, the weight assessment and counseling measures have all been removed, and then the new measures that are going to be followed in 2024 include well child visits for the first 15 and 30 months, cervical cancer screening, and then controlling high blood pressure. We think those are all important measures that do have a significant impact on population health. The weight assessment and counseling measures really weren't adding a great deal of value, so those can be removed without any negative effects on the population. So Dr. Mueller, would you like to take the next slide?
Yes.
Thank you.
Good morning to everyone, and I appreciate that I'm a new name and face for you. I appreciate the introduction, Dr. Bachman, and you will, of course, be missed in this work. I've been with Northwest Perm for about 3 years, and prior to that, I was a public sector county employed physician with Lane County, so I truly appreciate the work of my educator and public employee colleagues. So I look forward to working with you and collaborating with you going forward. For my part of the presentation, I'm going to talk about where we are in 2024. We know that this data is not complete. There's a lag here, but we can at least talk about where we are through November and look at some successes that we're having and also some areas that we've identified for places of continued work and growth. So what you're seeing in front of you for 2024 are measures for OEB on the left and PEB on the right that we are currently meeting or exceeding the 90th percentile. So for both the population groups, we're exceeding that 90th percentile for cervical cancer screening. Incredibly important work. And as Dr. Bachman said, that's a new reporting measure for us as of 2024 in this format. We are also exceeding the 90th percentile for breast cancer screening in both groups, as well as following up our hospitalization for mental illness hospitalization patients within 30 days. Important work. We are also exceeding the 90th percentile for eye exams as part of our comprehensive diabetes care strategies. You can see for OEB, we are additionally at or above the 90th percentile for immunization status for our children 2 and under, the combo 3 measure, while PEB is exceeding 90th percentile for adolescents, the combo 2 measure, as well as adherence to statins for 2 really important populations, are patients who have cardiovascular disease or diabetes. In addition to what you see on the chart, we are also happy to say that OEB is exceeding 75th percentile for 5 additional measures, not listed here, but those include the adolescent immunizations for combo 2, statin therapy adherence for patients with cardiovascular disease. 2 new measures that we were looking at in 2024, we're exceeding the 75th percentile for new well childcare visits, 15 months and younger, as well as between 15 and 30 months of age. And OEB is also above 75th percentile for colorectal cancer screening to round out some of our cancer work. Among the PEB group, we also have 2 additional measures that are not listed here where we are exceeding the 75th percentile. And that includes a number of our patients who have cardiovascular disease who are receiving statin medications and also colorectal cancer screens. So all good work, and we'll go to the next slide. There is always places for us to find room for improvement. So I'm going to switch gears a little bit and talk about some of the things that we've identified through 2024 that we are putting pretty intense work in to see further improvements in our data. I just told you on the previous slide that the OEB population is exceeding 75th percentile for well child visits and also getting our young children vaccinated. But in our PED population, there's a bit of lag in that data. We're not quite meeting that measure. Probably, I would say in prior years, we would be able to say the pandemic has really took a big influence on this, switching out well child care visits for sick visits and focusing on COVID vaccinations and things. But how much that's still in play is difficult to say. What I would say now is that we have new workflows that are trying to work aggressively on both of these measures for our PEB population and the population at whole. So for well child visits, again, we're talking about our young kids 2 and under. Previously, when those children were taken off of a list of, say, we need to see this kid, and they scheduled, if they didn't show, that child might be a little bit difficult to track after that. Now, if one of those young children doesn't show, we have an ongoing workflow that we piloted in a few clinics and now have spread region-wide, that family is contacted immediately to reschedule, just so we don't lose track of that child. We're also looking at opportunities for when kids scheduled to come in to talk about non-well child visits. So perhaps they're coming in to be seen for a rash or an ear infection or a general discussion. We have lists of those children that we know we need to catch up for well child visits. And so our back office staff will make notes on the chart saying, if it's appropriate, try to get that work done today. We can get more than just that simple complaint done. But if it's not appropriate that day, we have to handle a sick visit, then we are going to schedule them at that moment in time for well child care in the future. We have a pretty robust centralized outreach system that we've worked on this year to first give automated reminders to families. We need to get your kid in to be seen. And if we don't have success there, then we're having in-person phone calls. We talked about the success of the OEB group with getting our young children vaccinated. Still a little bit of work to do on the PEB side, but things that we're working on in that area is that we want to make this as easy as possible on families to get their kids in to get vaccines done. So we've expanded our MA templates, medical assistant templates, and RN templates so that families can schedule just to have vaccines done. They no longer have to search for that opening with the doctor to get all of that completed. So we're trying to make that a lot easier on families. We're also working with our specialty pediatric colleagues. We know that if your young child is seeing a pediatric gastroenterologist or a neurologist, perhaps the focus is in that area for care of your child rather than getting in for a well child visit. But when our pediatric colleagues are seeing those patients, we can close vaccine gaps at that time as well. Next slide, please. A few more areas that we've had pretty intense work through 2024. As I talk through some of these measures, they're a little bit more dynamic than did we get the vaccine done or not. You can imagine controlling a person's blood pressure has lots of different factors. And every time we see that patient, we're making sure that things are still on the right track. We are not where we need to be right now for OEB and PEB. And so some of the things that we've done throughout the year, pretty intense work, and I'm seeing the fruits of our labor as a primary care doc. We've increased the number of blood pressure pharmacy clinics. These are done a little bit differently in each medical office building, but in my clinic, these are done on Tuesdays. Patients who have been flagged as out of range for blood pressure come in, meet with our MA. They have 2 blood pressures done a few minutes apart. If the second is still out of range, they're able to consult with a clinical pharmacist about possible titrations of meds. They work on a strict protocol that's physician-led and approved, but they are able to see patients in between visits with their primary care doctor and get us a few more touches at good chances of getting their blood pressure in control. We also have a new enhanced RN blood pressure visit template. So patients can come in and visit with our nurse colleagues. If they're on no blood pressure medicines or perhaps one, there's another strict protocol that our nursing colleagues can work within at the top of their license under the guidance of doctor. They often come into these visits and get extra lifestyle counseling on ways to control blood pressure without medications, but they are exceptional support and supplemental support for our blood pressure patients. We've made this referral new and simplified. So I, as the primary care doctor, if you're in front of me, your blood pressure's out of control, I've got a lot of other things we're also working on, and I might want a few extra touches in between. Then I place a referral, and depending on number of medicines, 0 to 1, you may see my nurse colleague. 2 or medicines higher, we might be working with a pharmacy colleague. At the time that I recommend this, I can direct book you into that, so you know which one of my colleagues you're going to see, why, and feel confident about how we're working together to get blood pressure in control. We also have automated reminders for lists of patients who are remaining out of range to get them back into clinic. Life is busy, but to get more touches to see if we can get them in better control. For our diabetic patients who are not achieving good control, defined as an A1C is 9% or higher, our workflow looks pretty similar as to the changes we've made with hypertension. So we've enhanced our multidisciplinary team, again, including clinical pharmacists and RN care managers. They are able to, again, work on intense protocols that are doctor approved and led to help us do additional education. Many patients need just extra help on diet, checking their blood sugars, and also they can assist with titration of oral and injectable medications in between visits with your primary care doctor. Again, I can direct book into that clinic because of our integrated model, so they know exactly who they're going to see, why, and what our benchmark for success is, and when they're going to come back and see me to further the conversation. Our diabetes care managers also have what's called a grab and go list. So anytime our patients are getting an A1C done as a marker of where their blood sugar control is, our care managers get flagged by that, and then they know to intensify their meetings, reach out if things are going in the opposite direction of where we'd like to see. We also have pretty good automated reminders followed by live in-person outreaches to get our diabetic patients back into care. Regarding statin therapy, we are not quite at 75th percentile among our diabetic patients for both OEB and PEB. There are lots of, I think, perceptions about statins out there. I see this in my own practice, that patients have tried these medications and for one reason or another feel like maybe there was a side effect they didn't like. So it's often the truth that we can get a lower dose of medication or a different one in the same class that we can get patients onto to make it more effective for them, because we know diabetes is a cardiovascular disease equivalent, and these medications can be really important in this group. So our pharmacy technicians are using motivational interviewing to reach out to patients and say, tell me about your experience. Can we look at this again? It's a huge help to me as a primary care doctor. Our pharmacy technicians are scheduling these appointments, so it's not just an on-the-fly cold call. These are actual times dedicated where patients can chat with our pharmacy colleagues, and we're finding this to be successful in getting those medications back on board. It's also a clear clinical care gap that is right on the front page of the electronic health record. So when I am seeing you in clinic and we've talked about your diabetes, I can tell right away that this should be part of our conversation if we can. Again, it's always shared decision with the patient, but things like statins are so important to work towards to prevent heart attack and stroke. CAPS is an area we are always consistently working to try and improve. We know one of the primary drivers of overall satisfaction can be access to care. So that's been an area we have really been striving hard through the 2024 calendar year to improve. Through hiring, expanding templates, and other consistent workflows, we've made a big jump in the number of visits for both primary care and specialty care. So comparing 2023 to 2024, we've seen a 12% increase in the number of primary care visits and 10% in total when we lump in specialty care. We know that people don't just want to see a provider, they would love to see their own provider. So the doctor or clinician that knows them best and has been working with them on therapy plans. So we work hard on getting patients in to see their own clinician. We are currently at a rate now through our efforts that about 84% of our patients are seeing their own doctor. And 64% of patients are able to access their doctor within only a couple days. And that's the best we've been in about 5 years. So really feels good to see that come to fruition. We know that back in the pandemic, when we leaned so heavily on telephone visits and video visits, there was a huge role for those. And while we're still using those and they have a great defined role, we know that patients were interested in getting back in to see their doctor face to face. So through, again, looking at templates and figuring out strategies to do this, we're now at a place that about 75% of our visits are face to face at members' preference. So we're happy to see that. We really pay attention to how quickly our patients can get in to see our specialists. So one of the things we're looking at through 2024 was the number of new specialty referrals that could be seen within about 2 weeks. I'm proud to say that we're now at a place that we're seeing about 60% of our new referrals in specialty care within 2 weeks. And because of our integrated model, that is really easy for us to kind of look at our specialty care appointments available and help with direct booking into those slots. So 60% within 2 weeks, and our average wait time for specialty care within our system is about 17 days now. Direct booking is so important, right? If you are in front of me and we decide together we need the help of a cardiologist, we can look at your schedule and their schedule and direct book you into that clinic. 45% of our visits are being direct booked in this manner now through some good efforts. And that's getting our patients in about 6 days sooner than on average before that process was put into place. Despite all the work we've done with access, we know there's a few other things that go into CAHPS scores. Patients want to know that they are getting a good interpersonal relationship with their doctor. So we're making it easier for patients to choose a doctor online that looks like they match up with qualities that they'd like to have in their clinician. And we're also working with doctors and our dyad partners to make sure that our patients are getting good experiences, the best care experience they can have when they're in front of us. And finally, I think we're just really focusing on some work that we know we are doing behind the scenes, but sometimes we have to remind or put that back in front of the patient. What do I mean by that? Patients want to know that we have good working knowledge of their full medication list. So really getting the patient involved in that medication reconciliation in front of them. And they also want to know that we're coordinating their care well. In our integrated system, that's easy for me to see notes from your nephrologist. And I can tell that your cardiologist changed your blood pressure medicine just yesterday. But it's important that we remind patients that we're doing that work and looking at all that. So part of that is just in our conversation. Next slide, please. The additional part that was requested of us today was to think through additional measures for consideration. So a couple of things that came to mind for us were, things that we take dear to heart and we're working on closely, but also measures that align with your strategic plan and focus on behavioral health. So two of the things that we think are really important is depression screening among adolescent patients and adults alike. And then not only screening for those, but when we do identify patients who meet clinical criteria for major depressive disorder, how are we taking care of them and monitoring that over time? So with our integrated behavioral care model, we may get patients who are interested in using some of our behavioral apps online to get care. They may be getting regular counseling, or we may be using pharmaceutical treatment or getting them under psychiatric care. But the entire continuum is important to know that we didn't just identify it, we asked the right question, but then we're taking care of it over time. And since we added child visits up to 30 months in last year, we believe it's important to consider following that continuum and looking at a measure of child and adolescent well care visits from age 3 to 21. So we're shifting from that intense period of time where young kids are getting vaccinated and we're talking about growth and development, and also saying we think it's important to make sure we're talking about those preschool years, school years, adolescent time, health risks, substance use, mental health, and then into establishing healthcare habits into their adulthood. Okay. I think that's my last slide. We can go to the next. And Dr. Bachman, if you have anything to add, otherwise we can open it to questions.
Nothing to add. Thank you, Mark.
One of the things we're talking about, this is kind of maybe taking you a little off topic, but just in looking at performance work coming up for the following year is female healthcare, specifically focusing on prenatal, birthing parent care, as well as menopause care. Do you see any kind of issues or talk in that area just for a minute?
Yeah. Well, prenatal care, there are HEDIS metrics that can be used for prenatal care, and those have tend to run so high, both within our population, that we sort of stop focusing on them because we sort of have that. So we feel like we're providing that. It's a little tricky in terms of not just pre-pregnancy care and pregnancy planning. There isn't any really defined quality metrics for that, though it's certainly a conversations that should happen during general well care. And I think menopause is really challenging. It's really important, but how to structure that in it with a measurement strategy is, I'm not quite sure how to do that. So that would take some further work. But I think we're aligned. Those are really important. Just how to measure it's a little bit complicated.
So as for the upcoming year, I'm good with where we're at, but I just throw that out there for future thought, of where we want to look at some understanding and some concepts of how to improve in these areas for the following years, right?
I think calling attention to it, I think there's ways of doing that. So let's further that conversation.
Sure. And again, Keith, thanks for all your work with us. I know you've been here longer than I have, and I've been here a while. So, but yeah, really appreciate all you've taught all of us, especially me, in throughout the years.
Thank you very much.
Any other questions from SEOW members? Hearing none, we'll move on to MODA. Erica and Dr. Popovich, who's on first?
I will get us started. Okay. Good morning. Happy New Year to you all. And congratulations, Dr. Bachman. Had no idea that you were retiring. That's fantastic. So I'm, that's Providence.
Yeah, somehow we wound up on the Providence slide instead of the MODA slide.
I'm trying to go back.
Okay.
Okay. In the meantime, so I'm Yael Popovich, the Vice President and Chief Medical Officer here at MODA. We're very pleased to be here this morning to present to you our 2022-2023 quality measure outcomes. This is data that comes to us through our MODA 360 Health Context Engine, which for those not familiar with it is data that's acquired. Data that is acquired is used for member segmentation, risk stratification, predictive analytics, and personalization to improve health outcomes, reduce costs, and address disparities. This health context also helps us increase engagement in our programs by using that data to identify the right program for the member that it makes most sense for it to enroll in at the right time. So We are also extremely fortunate to have Adina Bailey here today. She is our supervisor of quality programs, a rock star, and she will be reviewing our overall results for commercial, CCM, PPO, and PEB plans, as well as discussing quality measure opportunities and strategies going forward into the new year. So with that, I'm really happy to turn things over to Adina Bailey.
Thanks, Dr. Popovich. As he said, we are going to be going through our performance of the 2022-2023, which is really the measure year 2023 quality measures, our HEDIS scores on that. So the results for overall commercial, which is our entire commercial plan, and then the segmented OEB, CCM, OEB, PPO, and PEB populations. Again, we're going to talk about some quality measure opportunities and strategies, and then upcoming measure changes into measure year 2025 and beyond. We go to next slides. So the way that we break it out for our points, we have 1 point for 66th percentile, 2 points for 75th percentile, and 3 points for achieving the 90th. It's a little bit different between the CCM and the PPO plans. Both OEB, CCM, and PEB are CCM, but we do have the OEB PPO plan, which is a bit smaller in population, and the point structure is a bit different, and this is how it works out. We can go to the next slide. So for this, anything in green font indicates that we hit between the 66th and the 90th percentile on the performance guarantees. So for overall commercial, you can see there's no performance guarantees there, but you can see where we hit. If it's a green on the measure year 2023, we were at least 66th percentile on those. And then we also have our overall rates for 2022. So you can see the difference between the two and hopefully some improvement from the previous year. For OEB CCM, we were on this slide able to hit at least the 66th for all of our measures on this slide. Slightly better this year for the HbA1c pore control than last year, and definitely better for most of them year over year on this. But we were able to hit for OEB CCM. OEB PPO, like I said, is a very small population, so a lot of times it rolls up to the overall commercial rate, which is why you're seeing the overall commercial rate as well, just because especially if it's a hybrid, which is a smaller sampling of a measure, it's down to a few people on some of them. So we have to go to the overall commercial on the PPO. And you can see we're doing better than last year on some of them. Some of them are right around the same, but not quite hitting the overall percentile for the colorectal cancer screening, because that was going to the overall commercial rate. For PEB, it's a smaller population than the OEB CCM, and it tends to be a bit of a healthier population, I think, in terms of people actually hitting the measures. So the measures tend to be a smaller sampling of people within our PEB population, so that does affect the dynamics of the rates. But you can see where we landed on those. Some of them are a bit less than they were last year, and we will talk about that in further slides. You can go to the next. And this is where we are for the rest of the measures. Same approach, 66th to 90th percentile is in green, and the overall rate for this year versus last year. Again, OEB CCM is doing well on most of them. We have some drops in statin therapy, which Kaiser spoke about as well. And then our CAPS plans remain about the same from last year. Again, PPO and PEB, smaller populations in the measures, so it does affect overall rates. We can go to the next. So again, our quality measures and strategies. For some of them that we didn't hit, like the CAPS measures, we do have a company-wide CAPS focus that we've been working on, which is going to be a multi-year focus, because CAPS really isn't something that you can fix overnight. It really is a year-over-year process. So we do have a new CAPS-focused team where we're partnering with Press Ganey, who is our survey partner, to create comprehensive strategies that will be multi-year and addressing member concerns based on the CAPS questions, and as well as additional questions that we add to the CAPS surveys, that we can kind of get a feel about how our members feel about our plan. For immunizations, which is both CIS and IMA, While we met for all of them for OEB, we are keeping a watchful eye on the decline in overall rates year over year, especially in Oregon. There tends to be less of a people actually getting their immunizations done. So we're keeping an eye on that. While we're still hitting, we do notice sometimes it starts to decline. We're doing EHR access and year-round supplemental abstraction to try to get the data into our systems. And we're doing enhanced member communication about the importance of childhood wellness visits and the vaccines while they're at their visits. We've also implemented member dashboard reminders about immunization and visits, so that we're looking at and focusing on members that haven't been seen that need to be seen. For statin therapy and diabetes and cardiovascular, we've changed pharmacy partners last year in 2023 to provide education to providers and pharmacists on the importance of statin use for members with diabetes. We're exploring additional member-focused calls now in the future to communicate with members about addressing the importance of their statins as well. We can go to the next slide. For plan all-cause readmission, we met, but we're looking at continuous monitoring of using hospital admissions and discharges to monitor members that are being seen in the hospital. And we're ensuring that appropriate follow-up is administered with our transition case management team outreach, as well as updating our internal systems for better monitoring with our vendor solutions. For diabetes eye exam, we are exploring mobile eye clinic opportunities for members that might live in areas where they aren't able to get to eye doctors. We are exploring member-focused communication regarding diabetes health education and care resources, not just eye exams, but all aspects of diabetes. And we're implementing diabetes eye exam care reminders through the member dashboard that we spoke about earlier, as well as Livongo. Child wellness visits, we are enhancing member-facing communications with child wellness visits, as well as really segmenting the SEOW population to try to find out what kind of barriers our members have to seeking out wellness visits or going in, both for wellness and immunization. We've implemented member dashboard reminders about wellness visits as well, as I spoke of earlier. We can go to the next slide. So colorectal cancer screening changed a bit this year. It used to be a hybrid measure, but it changed to electronic clinical data systems, which is ECDS. So there is no more hybrid component. We have to do only administrative and supplemental gap closures. So it does change. It did change the rate slightly because there was always a big jump for hybrid, which is basically going in and looking at charts and finding historical colorectal cancer screenings. So we are focusing on getting better data to be able to close the gaps, but we also are working with OEB and Cologuard to deliver fit DNA kits to members, just our OEB members, and that happened late 2024. So it just started, but we will be monitoring it. But basically, fit DNA they deliver a 3-year compliance because they're a little bit more in depth than the regular FOBT or FIT kits, and which only measure your compliance for 1 year. So we're hoping that will bump up the rates for colorectal cancer screening, as well as monitoring our members for their health regards colorectal cancer. And we can go to the next slide. So program changes for 2024-2025. Again, I mentioned that colorectal cancer screening is an ECDS only measure. For well-child visits in the first 30 months, as Kaiser spoke earlier, that is replacing the weight assessment and counseling for nutrition and physical activity for children. And then also controlling blood pressure and cervical cancer screening has been added for this year for 2024-2025 PGs. You can go to the next slide. For the well-child visits for the first 30 months, the NCQA has decided to remove the ability to use telehealth visits for this measure, which could potentially affect overall compliance with this measure, because there might be some members who live farther out or just aren't able to get to the office, have been utilizing telehealth visits for this. NCQA will no longer accept that. So it will only be in-person visits that will be calculated for this measure. And then also the following measures will no longer be considered hybrid, which means we can't do chart chasing on a smaller sample of the members during the hybrid season. We can only use our overall rates for the whole year. And that would be cervical cancer screening, childhood immunization status, eye exam for patients with diabetes, and immunization for adolescents. We can go to the next slide. And that was it. Do we have any questions from Hoda?
Yeah, on that last slide you had up, why the change from not counting telehealth? What is driving that in your opinion? It's not your change. I realize it's being driven from outside, but what do you think is why that change?
I think because NCQA is trying to phase out a lot of the COVID rules that they put into some of the measures for the years that we were like fully in COVID. And I think that they think this one is one that they can start to phase out. And I do think they probably will start to phase out more as well as it goes in. They really want members to go into the office versus telehealth.
Really? I was considering this kind of a COVID keeper lesson.
I would have loved that, yeah, but I just feel like NCQA is not going that direction, but we'll see.
And my second question is also an opinion question for you as the lead on quality. So as you know, OEB and PEB, we have a lot of these programs that we do with contract work for behavioral management or behavioral control, weight management, diabetes management, blah, blah, blah. How do you feel that those programs through your dashboard is being accepted and used and improving your metrics that you present here?
I think that it's slow going, but I do think that they are being utilized. We have a pretty comprehensive team that works with members with especially with disease states like diabetes, to really keep them focused on their health and going in and getting all the different tests and things that they might need. Sorry. But I don't know, Dr. Popovich, do you have some additional thoughts on that?
I think they're extremely helpful. And again, this goes back to the MODA 360 and the health context, being able to prioritize programs for our members so that they're not getting bombarded with every program that we have, but the programs that really do make the most sense. And we do also try to stagger that so that they don't get these messages right on October 1st, because we know that there are other vendors and other programs that may pertain to them. And so we try to stagger that out a little bit so that they don't feel quite as bombarded with the messaging from us. But we really try to target our messaging as best we can and really try to target the programs to the members that would likely most benefit in a non-confrontational, friendly, accessible way.
But your
this
summary.
Is April.
Oh, go ahead. Go ahead.
Sorry, I just wanted to layer something in real quick. I'm April Canetto. I'm the Director of Quality and Pop Health here at MODA. And I think just to kind of piggyback and do a little bit of additional layering, when we find that our population is able to engage in our programs, we find that we have pretty significant return on investment associated with that around condition management and support, looking at metrics around things like, utilization, different avoidable costs that we kind of bucket in the bad cost category. What we really struggle with is that engagement component and really focusing on how we're ensuring that we're able to reach the population, especially when we don't have the tools, right, such as like email addresses that really help us to reach the population effectively and engage them digitally. So we have been a lot of workarounds, but what we find is that when we are able to reach the individuals and we are able to engage with them, their outcomes are really positive.
Exactly where my mind is at is that ability to reach them is being throttled due to, various rules and policies and regulations, blah, blah, blah. But at the same time, you have a dashboard that goes in front of the people that can really also communicate with them. And I was just wondering, how that is being engaged. Not saying that should be a performance guarantee or anything like that. I'm just really functioning on, I see a lot of good measurements here. I see numbers that are on the climb. I see, like, for example, breast cancer screenings are high. in one population but not in another. So how do we target in to try and drive that earlier engagement with the healthcare community using these functions, just making sure we're actually doing some good, or are we not? It's just kind of my statement, right? That's why I wanted to get your opinion. I stated this as an opinion question, right?
No, I mean, they're all really great points and things that we have dialogue as well consistently about. And I think with our member console and with what Dr. Popowich was speaking to around the personalization engine, that's really identifying what we like to call the next best step and making it really clear and easy, like the top 3 programs that we're referring or recommending individuals engage in. We are able to analyze data to understand what population that is and whether or not they've engaged in programs. So that's information that we can also include in like our MODA 360 reporting, but those are things that we're looking at, to your point, to understand how it's driving some of our outcomes, where, for example, we don't have the ability to do other types of digital engagement.
Mm-hmm. Yeah, and on the other side, I realized that nationally we're way down on immunization, especially childhood immunization. That's a national problem we're having, and it's also here, right? And it's going to be a problem. So that's
there's some cultural things that play also just geographically, right? And what some of different kind of social patterns are.
Yeah. And there's going to have to be a relearning of what life was like before some of these modern vaccines, right? Because people don't remember, right? What was really there. Or we need to get Hollywood to reemphasize it in entertainment of what life used to be. Well, enough said about that. Yeah. Anybody else on the board or on the work group, sorry, for questions on MODA?
Yeah, this is Dr. Lara. So can you expand a little about the mobile eye clinics?
Mobile eye clinics?
Yep.
Yeah, Adina. I think we might have lost. Oh, go ahead.
What was that, April?
No, go ahead, Adina.
It's something that we're exploring about sending out mobile eye clinics to members in especially rural areas that we might have within Oregon, but also other states that we have, to try to get them to have their eye exams done, not necessarily just the diabetic eye exams, but also just eye exams in general. It's nothing that's solid yet. It's just something we're exploring. I don't know, Dr. Popovich or April, do you want to piggyback?
Well, I would say it's also it's similar to what we do on the dental side of MODA, where we do have mobile dental clinics that we send to the more rural, less accessible to dentist areas to try to provide the care that's lacking in those geographical areas. So it's following that model, but with eye exams.
And do you have like expected date to start these services, or just in the beginning of just assessment and all that planning?
I can address that. We're in the assessment phase right now, so we don't have any hard dates around where we would be looking at implementation, but we would be doing this initially on a small scale and doing like a PDSA cycle associated with it to understand whether or not it actually is effective in driving even small improvements. In eye exams, we're also looking at the ability to align it, for example, with where there might be some health fairs occurring, where there might be targeted populations that are within those health fairs that are that have kind of some adherence challenges around eye exams. So there's a couple of different approaches that we're looking at. We would ideally like to have it done by the second half of the year, but we're still working on looking at partners associated with this.
And do you think we are going to have some data by the end of the year?
We will absolutely be measuring it, as I mentioned, through what are the PDSA cycles, to see if it actually was able to have any impact on our adherence rates in the populations that we tested it in. So yes, we will be able to provide that to you. If we are at the timing, to your specific question about by end of year, it's really just going to depend on when we're able to implement this. It's possible we would have some data by the end of the year. It may be more likely that we would have data at like the end of Q1 of 2026.
Okay, thank you.
No problem.
Is this program a MODA thing for OEB-PEB, or is it a MODA thing in general for the state and working with your carriers or working with your providers?
We're investigating it as a MODA strategy that we would be able to leverage to support the OAB and PEP population as well.
Okay, but in general, would you be working through the education system or just through your provider clinics?
We are still possibly both, to be honest, depending on the implementation approach that we take. There may be a bit of both of those strategies at play, but initially we're going to be focusing on how we can align this with our provider partnerships.
Okay, got it. Thanks for the for the update. All right, any other questions for MODA on their measurements, MY measurements? All right, hearing none, let's go ahead on to Providence. And who was Providence? Sorry, Providence, I'm an OEB guy, so I'm not totally familiar with all your staff.
That is, this is Dr. Laurel Soot. I'm happy to take over. Take this on. I just want to thank everybody today. And for those of you who may not know me that I've met, Dr. Laurel Soot, general surgeon by training. I've been with the health plan for almost 9 years now, but stepped into the role of chief medical officer 1 year ago. Prior to that, I was in clinical practice at Providence St. Vincent's, did my medical school training at the University of Washington. So very, very familiar with the Pacific Northwest and the care that we can obtain and deliver here in Oregon. So it's a real pleasure to come to you today to speak to you about our performance guarantees, how we did, and our quality improvement. Next slide. I know you've seen our promise. Oh, can we go to the one before? That's fine. I just wanted, there was one more slide. Oop. There we go. Yeah, I just want to kind of realign everybody to our promise. And as a prior practicing physician, this really, in our Providence facilities, this really does sit with me. You've seen a lot of numbers today. You're going to hear more numbers from me, but truly, it is your employees that we care about. They are members. They were our patients, my patients. And at the end of all of this, I want you to have a clear understanding of where we are performing very, very well and really acting on this promise, and areas where we are continuing to drive towards improvement where we did not meet. We have very detailed information on our performance metrics at the appendix of this deck, very similar to what you've seen from Kaiser and MODA. They're also on the agenda PDF if you want to reference those as I go through my slides. But I really wanted to speak more to these measures. And at the end, hope you have come away with a good understanding of where we are as Providence Health Plan. So next slide. To set the stage as well is to remind everybody, we have PEB and we have both a choice and a statewide plan. Both our choice and statewide plan delivered on the quality of care metrics at the highest level. And the difference, though, that you're going to see, and you're going to see this play out, is that our choice plan is an integrated care model. The members are required to select a primary care home, medical home, and the medical home benefits these members with improved care coordination to specialists, more involved providers, and better communication with their care team. And so you're going to see that some of these areas where we need to improve are really in that statewide. So I just wanted to keep it really crisp on this, is that we have the statewide plan and we have the choice plan with the integrated medical home model. Next slide. Where we did well is in our cancer screenings. And as a prior breast cancer surgeon, this set well with me, I'll have to say. Our colorectal cancer screenings for both the choice and the statewide performed at the 95th percentile. Our breast cancer screenings were at the 95th percentile for choice and the 75th percentile for statewide. Obviously, critical for reducing healthcare costs. Early stage treatment is more effective, and you have productive employees who are able to really work and undergo their treatment at the same time. Diabetic care, also consistently performing at the 75th percentile and above, and often into the 90th percentile for our diabetic exam and hemoglobin A1C, again in our choice population. So good management of the diabetes leading to longer term health outcomes for these members as well. Pediatric well-being, we achieved the metrics in the 75th percentile for both the choice and the statewide plan. And in the adolescent immunizations as well, we saw significant improvements in 2023. The choice plan went from 67 percentile to the 75th percentile, and statewide had a huge jump as we put into some programs to really emphasize adolescent immunization. So we were at 33% in 2022, and we jumped to 75% in 2023. So really seeing some improvements there with some critical outreach to that statewide plan that is not medically managed. Next slide. You could say, well, how did you do this? One of the ways, and I love that because this kind of ties into some of the questions that just came up around partnerships. Not only partnerships with our providers and groups, but what are some clinical digital partnerships that really can move the needle? One of the things that we have done is with Virta, and Virta is started as a diabetes management program. They still are. They do an excellent job, evidence-based review. They've now moved into that sustainable weight loss realm as well, but we've been working with Virta for 6 years. So the PEB members have had access to Virta for diabetes care in the last 6 years. And you can see over here on the right side what this does. When you engage with a partnership that really can engage with your members and work together. So the A1C change for a usual 1 year for members who are not in the Virta program it actually went up. But with the Virta program went down by 1.2. That really, when you see a 1 point change in a hemoglobin A1C is when you can start measuring outcomes from reduced readmissions. What does this mean for medical management? As you can see, what this also equates to is a weight change for your type 2 diabetics, a 10%. Right when you see about a 10% weight change, again, is when you can start measuring what it means from an economic and a cost of care metric. And the medication change was really significant. This went down by 39%. That has direct financial ramifications as well as health ramifications of improving the health and decreasing the cost of care. And so when it comes to these clinical digital programs and partnerships, as the Chief Medical Officer, that's what I'm looking for. What is underneath this? What is the win-win, which is decreasing the cost of care and improving healthcare outcomes? And we're just excited with this partnership of Virta, and we're continuing to explore other partnerships that are very similar. And this is the kind of outcomes that I'm looking for and asking for as we look at these newer solutions. Next slide. So we are committed to growth. We are committed to access to care. So where did we have issues? And you've heard this from Moda and Kaiser. Right now in Oregon, it is extremely challenging. Some newer data that just came out is there were more physicians that either retired or left the state of Oregon than new physicians with medical licenses. So we do have a critical access problem within the state of Oregon, and the PEB members are experiencing that. So things that we are doing as the health plan is continuing to expand our network, not just our bricks and mortar, which we absolutely are doing, but also, again, these really critical clinical digital projects or telehealth products that will get them the access that they need. One of the areas that we also saw a real marked difference is in our statewide versus our choice for follow-up hospitalization after mental illness. Our follow-up hospitalization for mental illness in the choice population was extremely high. It was in the 90th to 95th percentile, and our statewide was only in the 25th to 33rd percentile. Again, looking at that coordinated care model. We saw that, and that's why I wanted to point out that adolescent immunization where we were at a 33% and went up to a 75%. So what can we as the health plan do if this member does not have a medical home? And I'm going to talk about that on the next slide. And it's also for the choice members, but we're seeing where this gap is with the statewide members. And then like the other carriers have shown you, immunization in Oregon for childhood immunization is very, very challenging. We're doing some things to incentivize providers, educate the membership, but this is a challenge, as the other providers have or payers have talked to you about. Next slide. So what are some of the ways that we can improve access? One of the ways we really can improve access is with our Providence Medical Group Bridge team. They will give exclusive access to all Providence Health Plan members with a phone line and an onboarding with a nurse within 72 hours of coming onto the plan. We're able to obtain their medical records and transfer care for new membership, and they can access the medical group services prior to actually a one-on-one appointment with a new provider at Providence, which means any refills that need, any specialty referrals, virtual visits, labs, imaging, things that you normally would have to have an established primary care physician for. The Bridge team can do this as we're getting that member into a new established primary care physician. And that's for both statewide and choice. This allows us to establish this care, again, act on our promise to really say, I know you, I see you as a member of us, and I want to take care of you, and I want to make this easier. So this allows that seamless transition into a primary care community and medical home. We also really believe that this reduces the need for emergency care or urgent care, trying to get, figure out how do I get my medication refilled, or any complications that can occur from not having your medication or not having the testing that needed to be done. Next slide, please. So behavioral health, huge issue. And we also see this in our pediatric and adolescent population. So when we're looking at follow-up after hospitalization for a psychiatric disorder, what are those things? Some of those big things are substance abuse, suicide, eating disorders. And where we have been able to kind of thread the needle there is with these telehealth providers. So these are providers, it's not a it's not an app that you're going on. Those work great for certain things, but not for people who've been hospitalized for psychiatric, or you're trying to prevent a hospitalization. So we have Charlie Health, which is a virtual intensive outpatient therapy that involves the family as well. So this is with teens and young adults ages 11 to 30. They get immediate access within 24 hours. It's flexible scheduling, mornings, afternoons, evenings, Saturdays, personalized treatment plans, and they do group and family and individual therapy. So the whole goal of this is to prevent the admission, or that will follow-up, intensive follow-up care. Intensive, what we call IOP, residential IOP, is very expensive. And there's not a lot of those services available. So this addressed an access issue as well as a cost issue, and has very, very high quality scores for this program. We have behavioral health concierge for all of our PEB members, and they can access virtual, confidential, same day or next day appointments at no cost. And these are Providence licensed medical health providers. They help with mental health, substance abuse, support for their families, counseling. June Care is a virtual suicide and crisis support for teens and young adults, ages 13 to 26, and these are with licensed therapists. Talkspace is our telehealth provider of virtual psychotherapy for both teens and adults. And that's what we found when we were starting to look for these abilities. How do we access care? How do we get people care when they need care? Many of them were limited to adults. Talkspace is ages 13 and above, and they're matched with a provider within 48 hours, connecting through however they want to connect, whether it's text, call, or live video. VITA is a 12-week telehealth program that serves all diagnoses, but definitely is specialty in suicide. So again, trying to really deal with the mental health issues after admission, and what I would love to do is just prevent the admission from happening in the first place. And again, this is ages 12 and above. They specialize adolescents, college students, adults, and veterans, because we know that they all have very specific critical needs when we're looking at suicidality. And it has nationwide coverage as well. And these are sessions with licensed therapists. And then finally, EQUIP, virtual eating disorder treatment that starts with children as low as ages of 6. We are starting to unfortunately see significant eating disorders in very, very young children. And it's a family-based treatment, multidisciplinary, again, evidence-based, with a therapist, dietitian, mentors, and peer mentors as well, which can be very, very helpful for these adults as well as the children. All right, next slide. Immunizations. These are absolutely a top priority for us. As a physician, clinician, we don't need to really talk about why we need these. It's just very, very unfortunate. And I really don't want to see an iron lung coming back or polio. When I started my medical school training, I remember seeing some of these individuals who had had polio as a young child, and we definitely don't need to see that. Mumps, measles, all of the outcomes that happen from that. What we are doing is incentivizing our providers through our Pay for Performance program. We're keeping our members educated, trying to empower them through targeted mailers, specific calls to action. And as the other carriers have also noted, we're preparing for these data reporting changes as HEDIS is going to be retiring their chart review measures and converting to the electronic data reporting. Next slide. This is just to show you, again, in just a little bit of a different visual, what's happening in Oregon as compared to nationally, and why we're different. So when you compare Oregon benchmark data to national benchmark, you'll see that if you were going to obtain 90th percentile for Oregon, you're actually significantly still below a national 66th percentile. So for an example, both our PEB statewide and choice did not even meet the 66th national percentile thresholds, but they did achieve 75th and 90th percentile Oregon, respectively. So it just shows that our providers are trying really hard to address these gaps. This improvement is going to take time, education, and there's just some reasons why Oregon is different in this realm as compared to some of the other states. Next slide. So in summary, again, I want to thank you for the time. We can review any of the details in the slides in the appendix, but some of our recommendations are twofold. One is this childhood immunization benchmarking. I do think it is critically important to continue to track this. The issues that will come out of failing to be immunized and having an acute hospitalization are not going to be insignificant. These can be extremely expensive, as it may drive your cost of care and hit some high dollar outlier cases that I think you're going to need to be aware of. So I want to continue to follow this trend and see what we can do, again, from an education standpoint. But what we may want to consider is moving that benchmark so that we're not looking at a national benchmark, because we're starting at such a low number compared to nationally, but can we move that benchmark to an Oregon benchmark to recognize that our providers really are trying very hard to vaccinate and educate in a unique and community environment. The other thing I wanted to call your attention to is breast cancer screening. Right now, we're doing well. We've met our metrics in both the statewide and choice, but there's a new guideline come out by the U.S. Preventive Services Task Force, and NCQA is changing the HEDIS breast cancer scoring measure in 2025, going now back down to age 40. So breast cancer screening from age 40 to 74, it was at age 50. And so we are going to really be putting an outpush and encouraging, because this is the PEB population, that these new age group, age 40 to 49, need to really get their breast cancer screening done. And so that's where we're going to be putting some emphasis in as well to educate on this new guideline. And so next slide. I think that's the end. Thank you. Happy to, again, I mean, the upcoming slides, we can review these metrics in detail, but happy to take any questions that you have.
All right. I think our PEB friends will be more familiar with some of this stuff. Andrea, do you have anything you want to bring up here? Greg?
No. No, this is Greg. No, sounds good. It looked like there was a hand there.
Yeah.
Oh, yeah.
Agree with Greg.
I see a hand. Charna.
Hi, this is, thank you, Bill. This is Sharna Freehan. I'm the Health Equity Work Group Lead for PEB and OEB staff. And the one question I had for you was, way back in the beginning, we had a slide about the onboarding nurse having a contact with a new member, a member that maybe has moved over from another plan. And my question for you was, does Providence reach out to that person, or does that person have to call the Providence 800 number and get connected, please?
No, so we get what we call, whenever we bring on a new member, we get what's called a gap analysis, or we get that membership. So we can understand if when they transition over, was their primary care physician within our contracted network, or was it not? If they're within our contracted network, that's just a smooth transition. If we see that, say, somebody's come from out of state, or PEB brings on any new member and does not have an established primary care, we will reach out with bridge team information, specifically also as well as if we see a diabetic. We have our care managers become very involved in any transition of a member in active treatment for cancer, so chemotherapy. Any member with prescriptions that require especially a 30-day prescription, we make sure that those members can get in and be seen. So we have lists of new members, whether it's the physician that they're actually seeing and their medication list, because sometimes you may not get it as much from that physician, but that medication list will tell you this is a member that needs to get in. This is a member that needs to be seen. So we will do active outreach and also inform any new member coming in about the Providence Bridge team access as well. So we try it in multifocal, because as Yale was speaking about, engagement is hard. You get sort of this inundated with things, and you don't know, who do I call again? How do I do this? What? So again, Harley, really, truly, I mean it, like acting on our promise. This is hard stuff. This is complicated, and getting a new insurance is complicated, and it seems overwhelming. So what can we do to say, I know you, I see your medications, I see who your doctor was, you're fine, we're good, or let's help you with this transition, and make that easier for them, is really what we're trying to do. So I'd say it's both. They can call to our customer service line, and we help and assist and let them know their primary care docs in network, no problems, keep going. Or do we have an issue? Let's contact the bridge team. Let's get care management involved. Let's get them plugged in.
Thank you for that clarification.
All right, I have a question about your point solution contract partners that you talk about, Verta, and some of these ones on the modern solution for behavioral healthcare. Are all those partnerships, does the member engage with that through a referral from the primary care physician, or is there general access through there that you advertise that these are services provided that the member should consider?
Great question. With our behavioral health, we work with our behavioral health providers to let them know about these opportunities and these options. We also will directly reach out with care management with these. Verta, I think we have Sean online. I'm happy to take this question, but she also has a great relationship with Verta, and that's what we found too, is that this, you don't just sign on a clinical and just sort of hope a digital solution and hope that people find it. It's both. It's educating the providers, it's educating the members, and it's engaging the digital platform so that they have that opportunity to reach out to the members as well, if we have that contact information. And I don't know, Sean, if you want to take that a little bit and speak to our Verta relationship and how our membership knows about them.
Absolutely. What we do have with the Verta population, so we're looking at those that are type 2 diabetics, and we do provide a list of those that we have within our system that have been diagnosed within our system as type 2 diabetic. We do provide that list to Verta so that they can reach out directly to those members. So they're not just doing a blanket email out to all members. We're really focusing on those type 2 diabetics. So Verta has the ability to reach out to them in an email campaign, which we do run through the PEB staff prior to sending out. Also, we do have Verta listed within all of our marketing material, handbook and everything, so that members, if they go to their My Providence portal, they can see that under the wellness resources as an option for someone that has a type 2 diabetic diagnosis. So we kind of get them in all different sides, but Verta does reach out directly to those members to see if they would like to engage within the program.
It's almost like an automated referral, right? And
yeah, exactly.
Or referral,
exactly.
Right? So that it will be there if required. When you're looking at these, and I'm just, again, I know you have more than this, but looking at the behavioral healthcare slide on my screen right now, how often you evaluate these partnerships, and how do you decide, to move on or to let go or to continue?
That is a great question. So a couple ways that we do that. Our behavioral health is in-house. We have a relationship with Carillon Behavioral Health, and they literally work, their employees are working with our employees. We're all sharing the same platform for case management. We have I personally meet with the behavioral health leadership once a month, and we review this information at a detailed level. Who's been admitted, who's at risk, who's utilizing services. And then we have a medical director, Dr. Paul Geiger, who has an extensive experience of inpatient psychiatric care. He still takes call at Providence St. Vincent's. He also really does the clinical review of these as well. So it's twofold. We use Dr. Geiger as sort of a external, no bias. Is this going to work? Is it not? Is it evidence-based? You can imagine in this space is astronomical. I mean, it's just trying to kind of weed through what's real and what's not. And then we also have the Carillon team who's done kind of that initial first pass. So what we do with these is Carillon will come to us and say, hey, I think we've got something really unique. We see a membership need, an access need. That this Charlie Health was really a great example, because residential intensive outpatient is so expensive and it's not well regulated as far as credentialing programs, evidence-based. And this Charlie Health came through, and both Carillon recommended it, and then Paul took a look at it. We discussed it, we reviewed the evidence, looked at what this was going to do, How are they going to access really that full circle? Walk me through a member experience. And that's what I always do. I want the member journey. I pretend I'm the patient or the parent of this patient. And I want to see all of the touch points and how you're going to address them to really make sure that this is something that we feel comfortable will absolutely act on our promise. Because the last thing I want to do is just put out a bunch of things and just hope it works, or it doesn't work well. And we lose somebody in that process, in that gap of care. So that's how we do it. It's twofold. First pass through Carolyn, second pass through Dr. Geiger. Then we meet, discuss how we're going to implement with our digital solution team.
So just to make sure I understood your opening statement. So I'm as an educator looking at June, Vita, and Equip, right? Those three in particular. They're in-house programs. They're not external partners. Those are in-house programs that you just give them names.
So they're external, but they have a contract with Carelon. So we're able to access them through our Carelon relationship, which makes it more seamless because everything can then plug through Carelon, and then they attach to the June, so that the overall contract for the June care goes through Carelon. And because we have a contract with Carelon, it's just an additional offering. And Carelon allows us to pick and choose what additional offerings we want based on our needs.
And then my follow-up also, and you're talking about how you select a program, but how do you choose to maintain it to continue? How often do you review?
Monthly. I mean, that's something that has been really critical that I brought in. I'll be honest, because I didn't want to just put something on. Twofold. What are we paying for, and are we getting what we paid for? So service level agreements are critical. What are the outcomes, and is this giving us the response that we wanted? And what are the response times? The last thing I want to do, especially with a suicide and critical eating disorder, is to think that we're serving somebody well and we're not. And so part of these agreements with these digital solutions, you can almost think of them, because they're telehealth, it's like bringing on a new provider group. So we do the same vetting. What's their evidence? What's their quality of care? Again, really holding them to, are you really matching a provider in 48 hours? I need to see that data. When did you connect? How did you connect? And fortunately, Carelon, because they're part of this, does a lot of that work for us. But that's what we're looking for.
All right, understood. Thanks for that underground information there.
Yeah,
appreciate it. All right, anybody else for questions for Providence? Strolling along here, I see appendix. All right, I gotta roll all the way back up to the top of my screen here. Okay, I don't hear anything else coming along. That means we're ending a half an hour early. Rose, do we have any public comment?
No public comment.
Glenn.
Bill, I just wanted to clarify on the minutes. I think there was a bit of confusion. We had what we had done is we had put the May minutes up there because our first meeting was in December, and we didn't have a quorum to approve the May minutes.
That's right.
Which
Right.
So we had attached the May and December minutes, but we just did have the typo in the agenda that said September. It was December. So that's what was approved, was the May and December minutes, which were attached.
So I'll ask the board members, the 5 of us here, was that a problem? Anybody have any issue with that that's what we voted for? I don't think so, but no problem for me, right? So all good. So still the approval was good for what we had, like kind of a consent agenda. We did that as a consent agenda kind of item. So what was there, what was presented is approved, right? So I see the May and the September are presented. So okay.
The May and December. Sorry.
May and December. Yeah, right. So so next month we will have our membership names complete for SEOW, and we'll discuss leadership for that through the end of this renewal cycle. So through the end of June, basically through the end of May, since we don't really do anything in June except planning. We'll start looking for ideas, although we're doing it at the leadership team. But if anybody wants to contribute ideas, we have kind of a focus moving for this year to focus on women's healthcare, primarily around family planning and prenatal work, and especially a focus on menopause healthcare. So that's just a notice that that's kind of where we're putting our attention for this year. There's always the normal stuff about our contract point solutions and things that we review every year, as well as bringing in the renewal stuff that we have to do for just the metrics that we're doing right now. All right, anybody?
We'll have for February, what we're going to have is, Mercer is going to bring in for the PEB OEB for the upcoming renewal cycles, any basically clinical renewal suggestions that were provided through the initial renewal letter, and also say if there was a points program that was proposed. What they're also going to do is they've developed a set of metrics, and they'll have very likely we'll have the initial metrics review, but it'll just be behavioral health. It won't be every contract, every points program.
All right. Open the floor for Greg. I see your hand up.
Yes. Just so you guys all know, next month I will attempt to get internet access, but I will be on vacation. So.
In Antarctica? Is that why you're wondering?
I'll be on a small island in Mexico diving. So if you want to come along.
I think you can only get the signal about 5 feet down when you're underwater. So if you bring your laptop underwater, right, make sure you stay close to the surface. Right.
Thank you.
All right. Anybody else? If not, we'll call it a meeting. Let's adjourn at 11:32 for OEB members. I'll see you at 1 o'clock. Thanks, everybody.
Thanks, Bill.
Thanks, Keith Bachman. Thank you, Dr. Bachman, for all your service.
It's been a pleasure.
I was going to tell you, based on the